Hello, friends. My name is Dr. Achal Dhir. I work at London Health Sciences Centre, London, Ontario, and also associated with the University of Western Ontario in London, Ontario, Canada. I'm an anesthesiologist, and my special interests are liver transplant anesthesia, cardiac anesthesia, and transesophageal echo. And I'm going to talk about a patient with hypertension and coronary artery disease. Since this is a very long chapter and topic, so I'll be dividing it into maybe 2 or 3 lectures. So part 1, which is today, I'll be dealing with the management of patient with hypertension. And in next 40 minutes or so, I'm going to give you a little bit of introduction in the form of frequently asked questions, which we all have. And I will do it by giving you 2 case scenarios and some other frequently asked questions related to the hypertension. Then I will discuss about the physiology of blood pressure and the ways it is modulated in the body by different mechanisms. Then I will go on to discuss hypertension, its causes and etiology, how big is the problem, and what are the complications because of hypertension, and how can we manage the blood pressure in an outpatient setting, which are relevant to us as anesthesiologists. Then I will discuss about the perioperative management of a patient who has got hypertension. So our first case is a 65-year-old female. She's obese, and she says she's hypertensive, but according to her, she is controlled. And she's coming for elective knee replacement. She gives a history of MI 15 years ago, but denies angina now. There was no intervention at that time in the form of either PCI or CABG, and she has reasonably good exercise tolerance. And of course, pain in the knee and osteoarthritis limits her activities. She also had back surgery for spinal stenosis. So if you guys are thinking of going for spinal anesthesia, so I'm just wanted to discuss that she is not good for spinal candidate, so we have to give general anesthetic. So what factors should we consider for planning a GA for her? And what are our hemodynamic goals intraoperative and immediate postoperative period? And when you take her to the operating room and put her on the table and check the blood pressure, which shows 210 over 130 millimeters of mercury. So what do? Should we go ahead? Should we decrease the blood pressure by giving some nitro infusion or some other IV medication? So I will discuss that. Our second case is an 88-year-old male. He was admitted to emerge for acute stroke. Now he is being rushed to the neuroradiology suite for urgent thrombectomy. He is hypertensive, diabetic with mild renal impairment. He also had CABG about 25 years ago. In the neuroradiology suite, when you see him, his GCS is 12. He has left-sided hemiparesis and blood pressure is 190 over 110. This is an urgent situation and we cannot postpone this. And in fact, sometimes you do not have time to take full history or do full detailed examination of the patient. So how are we going to manage this patient? And what are our postoperative blood pressure targets in this patient? Other frequently asked questions or curiosity we have is, what is the ideal preoperative blood pressure? At what level of hypertension elective surgery should be cancelled or postponed? And how much time does it need after adequate control of the blood pressure to reverse the changes in the heart, that is left ventricular hypertrophy, left atrial enlargement, and diastolic dysfunction? So those are some of the questions. Coming to the blood pressure, which is a multiplication of cardiac output and systemic vascular resistance. Cardiac output we know is from the beating of the heart, and the heart pumps oxygenated blood to the tissues through the aorta, large arteries, and then the smaller arteries. The majority of the systemic vascular resistance occurs at the level of arterioles and smaller arteries, and these are the resistant vessels. So, a patient who has high blood pressure can be simply because of increased cardiac output, or can be because of increased systemic vascular resistance, or in many a times combination of both. So this is the TEE loop of a patient showing four-chamber view of the heart. This is the left atrium, mitral valve, and the left ventricle, right atrium, tricuspid valve, and the right ventricle. We can see the left ventricle is contracting well, and it is much thicker than the right ventricle. So the reason I'm showing you this is this heart is beating. The heart starts beating in very early fetal stage, usually around between 4 and 6 weeks of gestational life. It does not need the brain activity or brain function to start beating, and that property is known as automaticity. If we see, the SA node would be somewhere here at the junction of SVC and the right atrium. From there, that is the pacemaker activity starts. Then it goes to the AV node, which is at the lower part of the right atrium, and then through the bundle of His, the whole electrical activity is given to the rest of the heart. So the second property of the heart is chronotropy. That means it can increase the heart rate. That has the ability. And the conduction system through which the electrical current passes is known as dromotropy. So when the heart rate increases, we have to have the fast conduction, and with the dromotropy property, we can increase the conduction velocity. That is another property of the myocardium. Then, of course, we see it is contracting called inotropy, but equally important is that it has to relax to receive the blood in diastole from the left atrium to the left ventricle in diastole. And that property of relaxation is known as lusitropy. So we have inotropy, we have lusitropy, we have chronotropy, we have the dromotropy, and of course the most important is automaticity. So the heart does not need the brain to start beating. Then heart beats at about 100,000 times per day and pumps about 9,500 liters of blood every day. This is equal to the amount of force if you have to raise a weight of 1 ton to 10 meters. So this heart does every day. So it is a very strong pump, and with increased force of contraction, and it generates the pressure. The blood leaves the heart at about 1 meter per second speed, but of course, during stressful conditions and with extreme aortic stenosis, the speed can go up to 6 times, can go up to 6 meters per second. If we connect all the blood vessels joined together from end to end, and we will have about 100,000 kilometers of blood vessels in our body. Cardiac output at rest is about 5 liters per minute, we know that, and when we exert ourselves by simply walking, it goes up to about 8 liters per minute, and it has been noted to in marathon runners to be as high as 37 liters, indicating that it has so much of adaptability that the heart increases its cardiac output depending upon the demands of the body, and thereby it can cause increased pressure. And LV pumps the blood from extremities at the 6 times the force than the right ventricle. And since the force is so much, and when there is a weak spot in a vessel, it can cause aneurysm formation and also can lead to rupture of that aneurysm, causing stroke. So this is because the SVR is about 6 times more than the PVR. So as I told you, the heart does not need the brain to start its activity because of it has that automaticity property, starting with the pacemaker in the heart. However, when the demand in the body increases because we are exercising, we are running, we are jogging, or doing whatever, so now the heart needs the brain to control its activities and increase its output related to the demand. And so brain is very important to control the activity of the heart. And the maintenance of blood pressure is done in 2 ways, by 2 reflexes. One is the through the nervous system, which is very fast. In fact, it is every beat of the heart. There are signals going to the brain through the baroreceptors. And through these receptors, when the blood pressure, when the blood leaves the heart and goes into the aorta, there are receptors in the aortic arch and at the bifurcation of carotid. They are the baroreceptors. This means they are the stretch receptors. When they are stretched and the nerve stimulation goes to the brain, and in the negative feedback, it controls the blood pressure. During diastolic phase of the heart, the nervous triggers to the brain become less. And this is how every beat to beat blood pressure is maintained through this fast mechanism of baroreceptors. We also know that there are chemoreceptors at the same spot in aortic arch and in the carotid sinus, but these are responsible and get activated only when there is hypoxia, hypercapnia, or low pH because of acidosis. So they act only when there is some problem with the blood chemistry, whereas the baroreceptors are responsible for beat-to-beat maintenance of blood pressure. Then, of course, there is a slow pathway, which is the hormonal pathway, which is slow to respond, but once it is activated, it is a longer lasting response. And most of it is because of renin, angiotensin, aldosterone system. There are some other hormones also like vasopressin and atrial natriuretic peptide. Both are also to some extent control the blood pressure. But mainly it is the renin, angiotensin, aldosterone system from the slow pathway. So this is the heart who has, because of automyocytes, keeps on bleeding and beating, and this is the brain. And these are the aortic arch baroreceptors and at the carotid sinus. And when they get the impulse, the blood pressure is generated through the glossopharyngeal nerve. They send afferent fibers and relay it into the brainstem in medulla of the brainstem. Then the efferent part of the arc is through the vagus and through the sympathetic system. And as I mentioned, this is a negative feedback. The vagus nerve gets activated, or there is parasympathetic activity, causing slowing of the heart, causing vasodilation and decreased ionotropy. At the same time, also, there is a sympathetic system which is inhibited because of this negative feedback. So there is parasympathetic stimulation as well as sympathetic depression to cause and to maintain the blood pressure. So the afferents through glossopharyngeal nerve, efferents through vagus, as well as the sympathetic trunk to maintain this baroreceptor reflex. Coming to the renin, angiotensin, aldosterone system, we know that angiotensinogen is a protein which is produced in the liver, but which is inactive. So whenever there is sympathetic stimulation, there is hypotension, dehydration, or bleeding, or any other cause, or there is decreased sodium delivery to the kidneys. Kidney releases renin from the juxtaglomerular apparatus. Now, renin converts angiotensinogen into angiotensin 1, which again is still an inactive form, and a precursor of angiotensin 2, which is an active form. So, to convert angiotensin 1 into angiotensin 2, we require an enzyme called angiotensin converting enzyme. This is present in the lung as well as in the renal vasculature. So this enzyme is important to convert to the active angiotensin 2, and then that acts on the peripheral vessels and in the heart through the angiotensin receptors. It also stimulates adrenal cortex, thereby releasing aldosterone. It also stimulates pituitary to secrete vasopressin or ADH, and by these mechanisms, there is a fluid and sodium retention in the kidneys. And with the with the thirst mechanism, there is increased blood volume, and thereby the blood pressure is maintained. Angiotensin is also a very strong systemic vasoconstrictor. And lastly, and very importantly also, it causes cardiac and vascular hypertrophy. So if there is increased amount of angiotensin circulating, so you can expect some cardiac as well as vascular hypertrophy, which is another hallmark of hypertension. and systemic vasoconstriction. So this is a second mechanism by which the blood pressure is regulated in a normal situation. However, in hypertension, we see that this particular system is activated and becomes abnormal. So there is high amount of renin and angiotensin secreted and produced, causing all these changes and hypertension. I would also like to discuss about autoregulation. There are three systems or circulations in the body which are very important, and autoregulation plays an important role in that. One is the cerebral circulation, another is coronary, and third is the renal circulation. So we know that if the mean arterial blood pressure is between 50 and 150 millimeters of mercury, there is no change in the perfusion to that particular organ. So when we increase the mean arterial pressure to more than 150, for example, say it becomes 200, then we increase the perfusion to all these organs and related to the blood pressure. Then the blood pressure becomes important factor in increasing the perfusion, so we can cause cerebral edema or encephalopathy or maybe stroke in these patients. Or if we drop the blood pressure because of vasodilation or during induction of anesthesia and the blood pressure drops, then again the tissue perfusion is impaired. However, if the blood pressure is chronically elevated and patient is not taking any medication, is hypertension which is totally uncontrolled, we know that this autoregulatory curve is moved towards the right, it shifts towards the right side. The importance for us as anesthesiologists is we do not know at what level this is gone. So when the blood pressure drops after induction, so it is still says mean of 80, which is perfectly normal in a normal patient who has normal autoregulation. But in this case, where the curve has moved to the right, so 80 millimeters of mercury may become on the left side of this curve, causing hypoperfusion of the kidneys. And at the same time, if you prescribe some non-steroidal anti-inflammatory drugs, patient is dehydrated, the curve is moved to the right, and hypotension causing renal perfusion problems. So this is a recipe for having a postoperative renal dysfunction or failure. So to diagnose hypertension, we need to have two readings and at two separate occasions. This is the minimum to diagnose that person is having high blood pressure, elevated blood pressure, or hypertension. The person needs to be seated, feet on the floor, arm at the level of the heart, and there has to be enough length of the cuff to cover the arm. So this is how the hypertension or elevated blood pressure is diagnosed. This was another position statement by American College of Cardiology and American Heart Association, published in October 2017, and this was a game changer. This brought many of people who were supposed to be normal or pre-hypertensive, they suddenly became hypertensive or elevated blood pressure. So this was the change in the definition. So normal blood pressure now is considered as 120 over 80 millimeters of mercury. Elevated blood pressure is considered when the systolic pressure rises to more than 120 and less than 130, but the diastolic remains 180. We label it as elevated blood pressure. Then stage 1 hypertension is labeled when the systolic pressure is more than 130 but less than 140, and diastolic is between 80 and 89. Mind you, in the previous definition by the WHO, this was considered as pre-hypertension. But now there is no such word as pre-hypertension. It is called as hypertension stage 1. So the patients or people in the past who were not labeled hypertensive, they were pre-hypertensive, suddenly become hypertensive with this new definition. Stage 2 hypertension is when the systolic is more than 140 and diastolic is more than 90 millimeters of mercury. So this was the initial definition of WHO definition of hypertension, but now that is considered as stage 2. And hypertensive crisis is when the blood pressure is more than 180 over 120 millimeters of mercury. So what is the pathology or etiology of developing hypertension? We know that as we age, our arteries become stiffened and thick. So these Thick arteries are because of the media is more. There is a more smooth muscle in that. So thereby there is a decreased relative lumen compared to the total diameter of the vessel. So with that, there is also some endothelial dysfunction because of the calcium deposits, and there is arteriosclerosis. And whenever there is a vascular contraction or sympathetic stimulation or renin-angiotensin mechanism more, it constricts the vessel, causing increased SVR, leading to hypertension. The next stage of this would be atherosclerosis, where we see the distinct plaque inside the lumen of the vessel, but this is more so relevant in coronary artery disease or peripheral vascular disease. For hypertension, only arteriosclerosis is enough. This I'm going to discuss when I discuss about coronary artery disease in my next lecture. So coming to hypertension, about 95% of the times it is essential. There is no real reason or pathology found. It is simply because of age, race, and family history. We know that as we age, we have more tendency to become hypertension and becoming hypertensive. Race is equally important. We know that people of Afro-American origin or African origin, they have the tendency, they have the gene which will leads to sodium and water retention, causing hypertension. And family history, again, because of the genetic predisposition, we have hypertension. But more important, and I would like to stress here, is the lifestyle choices. And this is totally within our reach or our patient's domain that we can change that. These factors of age, race, and family history we cannot control, whereas these are the factors which we can and we should be controlling. So by physical inactivity, there is overweight, and with overweight, there are some extra tissues, with extra blood vessels, with extra oxygen requirement, putting extra load on the heart. And with extra vessels, they cause vasoconstriction and increase SVR. And the belly fat is known to release some vasoactive substances causing vasoconstriction. Smoking is equally bad. So is the increased salt in our diet or decreased potassium. And of course, alcohol and mental stress is equally important. So these are the factors which are modifiable. Secondary hypertension is only in about 5% of cases, patients where we can find the real problem causing hypertension. And the common one being renal origin, like patient with chronic renal failure will be hypertensive. Endocrinal ones, the adrenal gland tumors, either secreting glucocorticoids or secreting mineralocorticoids or secreting excess catecholamines can cause hypertension. So is seen with hyperthyroidism and pituitary tumors. Raised ICP significantly increases the blood pressure due to the Cushing's reflex, and obstructive sleep apnea patients also almost always have hypertension. Also, coarctation of aorta is known to cause hypertension. Another important reason is different medications, especially the birth control pills, over-the-counter cold medications, the nasal decongestants, and non-steroidal anti-inflammatory drugs. Drugs of abuse like cocaine and amphetamine can also cause sudden surges in the blood pressure. This is how these young patients who take these drugs can land up with the acute stroke. What is the significance or magnitude of this problem of hypertension? With this new definition, almost about 50% of the patients suffer from high BP. I mention high BP and not hypertension because many of them may have simply elevated blood pressure. And about 40% of these patients, the blood pressure is not adequately controlled. Maybe many of times the patients do not know that they are having elevated pressure or hypertension. Many times the medication is not fully effective. And in majority of the cases, patients, when they start antihypertensive medication, the blood pressure drops and they stop taking medication. So they are not very compliant with the medication. So it's a majority of the patients, and there are hundreds of thousands of patients are dying just because of hypertension-related complications. So as we age, and as I mentioned, the arteries stiffen, there is some arteriosclerosis. So by mid-50s, there are about 50% chances that person will be hypertensive. There is another study showing that at age 55, if person is normotensive, there is a 90% chance that person will become hypertensive in his remaining lifetime. So it is a real big problem, and it's a real killer. So the blood pressure level increases the cardiovascular mortality risk. So this was a study, which was an excellent study done about 18 years ago, and they studied about 1 million patient population and measured their cardiovascular mortality risk. And they divided into the groups of increasing the blood pressure by 20/10. So they increased the systolic by 20 and diastolic by 10 and divided into these categories and measured the patient's cardiovascular mortality risk and those who died because of cardiovascular reasons. So in a patient or in a person who had normal blood pressure has a risk of 1, which is normal for death. When we increase the blood pressure or become pre-hypertensive in the old definition to 135 or 85, we double the cardiovascular mortality risk. And we have the blood pressure into 155 or 95 range, which is secondary, stage 2 hypertension. There is a 4-time risk of dying because of cardiovascular reasons. And when there is a severe hypertension, then the risk becomes 8 times. Again, signifying that hypertension is a real problem. It is involving many patients. Millions of patients suffer from this. And if it is not well controlled, it definitely puts much pressure on the medical system because the cardiovascular mortality is very high. Coming to the perioperative hypertension, 90% of patients coming for cardiac surgery and 1/4 of the patients coming for non-cardiac surgery have perioperative hypertension. So the problem carries on into the perioperative period as well. The acute postoperative hypertension occurs in 1 of 5 patients in non-cardiac surgery and maybe up to half of the patients after cardiac surgery and between 9 to 64% after carotid artery surgery. Patients may be postoperatively hypertensive, causing major problems with increased cardiovascular events up to 35%, increased cerebrovascular events, increased bleeding, and of course, increased mortality because of these reasons. So hypertension is a big global threat. I'll discuss about revised cardiac risk index, which is used quite commonly recently. And it has 6 components, very easy to use and to stratify the risk for any patient coming for non-cardiac surgery. So one is the high risk surgery. That means any intra-abdominal, above inguinal surgery or intrathoracic surgery. So the answer is yes or no. Yes with 1 point each. Ischemic heart disease, CHF, cerebrovascular disease or history of stroke or TIA, 1 point each. Serum creatinine more than 177 or 2 milligrams %. And lastly, diabetic who is insulin dependent. So 1 point each. The reason I try to discuss this is because hypertension, apart from diabetes or surgery, all these 4 factors are related to the hypertension. So again, hypertension plays big role in the revised cardiac risk index and stratifying. And we know if score is 0, that means patient is coming for simple procedure. None of these, risk is very low, 0.4%. If patient with none of these but coming for high risk surgery, it is still doubled, risk is still low, up to 0.9%. But of course, when one of these factors is present coming for high risk surgery, it becomes moderate risk. The risk goes up to more than 6.5 times. And lastly, if the score is 3 or more than 3, it becomes very high. There is 11% chance of patient dying within 30 days after surgery or having a major adverse cardiac event. Major adverse cardiac events means patient may have MI, patient may have heart failure or dangerous ventricular arrhythmias or atrial fibrillation. So what are the complications of hypertension? Of course, the end organs, which is the heart, the brain, and the kidneys, are involved. In the heart, patient can have coronary artery disease. We know that hypertension is a risk factor for coronary artery disease. Then there is hypertrophy of the left ventricle, because the ventricle has to work against increased resistance and increased mass. So there is a left ventricular hypertrophy. Then there is heart failure. Usually in the beginning, it is a diastolic heart failure, shown as diastolic dysfunction. And lastly, because there is left atrial enlargement with the hypertrophy also, there is chances of patient going into atrial fibrillation or other ventricular arrhythmias. From the brain, it is a risk factor for stroke or TIA and dementia. In the kidneys, it can cause glomerulosclerosis and thereby causing chronic kidney disease or renal failure. As we know that it can form different aneurysms in the blood vessels. There can be abdominal aortic aneurysm, there can be thoracic aortic aneurysm, or there could be acute aortic dissection. You see these patients not unusual to have these patients in the emergency or in the cardiac operating room. Of course, hypertension can also cause retinopathy, changes in the eyes, optic neuropathy, and it can also cause sexual dysfunction because of it is a vascular problem, and when we need increased blood supply, and which is not possible because of vascular disease, so there is a sexual dysfunction both in males as well as in females. Now let us discuss about how do we manage the blood pressure. Again, I would not emphasize less on lifestyle modification. Majority of the times, the hypertension is because of obesity, physical inactivity, dietary habits, and smoking. So if we counsel our patients, even in the preoperative period, to stop these, we are doing something good. Just by losing weight, by dieting and exercising, stopping smoking is very helpful. And our target is to get the blood pressure in the range of 120/80, and anything less than 130 would be good. So this is the slide I showed you how the renin-angiotensin system works. So first and foremost, we do salt restriction, and diuretics are part of the first line treatment for hypertension. Then of course we can use ACE inhibitors and angiotensin receptor blockers. ACE inhibitors stop forming angiotensin 2 at all by blocking this enzyme here. So they also block, because of this, block the secretion of aldosterone. So thereby they can cause hyperkalemia, whereas angiotensin receptor blockers block only the receptors where the angiotensin 2 is working. So they do not cause depression of aldosterone, thereby do not cause hyperkalemia. Whereas both of these drugs are known to cause, because of the negative feedback, increased renin activity. But they are very powerful agents in the treatment of hypertension. Then, of course, peripheral vasodilators and calcium channel blockers are another mainstay of treating hypertensive patients. Beta blockers, again, because of sympathetic blockage and for other reasons, are also the second line of management of blood pressure. And sometimes we use in combination. Lastly, recently there are some anti-renin agents also used, especially in diabetic patients, in combination with one of these agents for the treatment of hypertension. So in stage 1, we start with diuretics, ACE inhibitors, ARBs, calcium channel blockers. In stage 2, or when the hypertension is not controlled with this, then we start combination of one of these, or we add beta blockers. So beta blockers are added only in stage 2 hypertension, but first choice would be one of these. There are miscellaneous agents in the form of alpha blockers or central alpha-2 agonists, like clonidine for hypertension, or there are direct renin antagonists. The one which is commercially available is aliskiren. So diuretics, what they affect are anesthesia management. So they, of course, because of the patient loses salt and water, so patients are dehydrated if they are on diuretic, which usually is masked and not overly seen. Diuretics are also a little bit of vasodilators. And if you're talking about thiazide and loop diuretics, they can cause hypokalemia as well as interfere with the carbohydrate metabolism, causing hyperglycemia. If we're using potassium sparing diuretics like spironolactone, they can cause hyperkalemia. So we should be aware of the side effects of these medications if patient is taking one of these. These diuretics should be continued perioperatively, including the day of operation in the morning with sips of water, unless you're concerned about severe hypovolemia or hypokalemia. So unless these are present, these drugs should be continued in the morning of surgery. Coming to ACE inhibitors, they end up with pills like captopril or enalapril. So these are very powerful antihypertensive agents, but we know that this enzyme, angiotensin converting enzyme, also destroys bradykinin in the lungs. So when we inhibit this enzyme, there is buildup of bradykinin in the lungs, causing the so-called famous dry cough of ACE inhibitors. It can also cause rash, and in some occasions also can lead to angioedema of the airway. So we have to be careful when this happens. And as I mentioned before, because of aldosterone system is blocked a little bit, so thereby can cause hyperkalemia. These drugs are known to cause refractory hypertension during general anesthesia, and which will not be responsive to your conventional vasopressors like phenylephrine, or you may have to give very high doses of norepinephrine or so. So for this refractory hypertension, it is nowadays recommended, and it is in the guidelines, that these agents should be stopped at least 24 hours before surgery. Coming to angiotensin receptor blockers, they end up with sartans like telmisartan or losartan. So these are again very effective antihypertensive agents, but they can also lead to refractory hypertension during anesthesia. So again, similar to like ACE inhibitors, they should also skip the morning dose. So the last dose should be a day before, not on the morning of surgery. Calcium channel blockers again are very popular and commonly used agents for hypertension. Agents from this particular category, especially the third generation amlodipine, is very common. It acts only on the peripheral vessels, causing vasodilation, does not act on the heart. Whereas agents from these two categories like verapamil or diltiazem also have action on the heart. They cause decreased contraction, decreased conduction velocity. So they are used more in patients who have some kind of supraventricular arrhythmias, like SVTs. So calcium channel blocker, depending upon what agent patient is on, they are vasodilators, can cause negative inotropy, negative chronoandromotropy, and they also potentiate the effects of inhalational agents. And we know because of neuromuscular junction is dependent on the calcium release. So when we are using this agent, so these drugs can potentiate neuromuscular blockage, something to be aware of. And these drugs should also be given in the morning of surgery with sips of water. Alpha blockers in the form of regitine, phenoxybenzamine, or doxazosin, they were given in the past, but they cause orthostatic hypotension, reflex tachycardia, fluid retention, and become less popular for routine management of hypertension. That being said, they are still very popular in the treatment of benign prostatic hypertrophy and in the treatment of pheochromocytoma. So if patient is already on these medications preoperatively, so again, these should be continued in the morning of surgery. Coming to the beta blockers, again, very potent and powerful agents. They are also used, apart from for hypertension, for other comorbidities in the form of ischemic heart disease, tachyarrhythmias, and CHF. Again, they should be continued perioperatively in the form of patient takes in the morning of surgery with sips of water. If they are very selective only on beta 1 receptors, they cause negative inotropy, decrease heart rate, and they can cause some kind of blocks, and they also decrease renin secretion. If they are non-selective beta blockers, then we know that beta 2 are in the peripheries and in the lungs. So they can also cause bronchoconstriction and vasoconstriction. So what are the side effects of beta blockers? Again, depending upon their pharmacological effects, if it is an overextension, that means bradycardia, they can cause some kind of blocks, they can cause hypotension and bronchospasm. Another point of note here is many cardiologists and internists do not prescribe beta blockers to diabetic patients, because if the diabetes is uncontrolled and patient was to go into hypoglycemia, which is in a normal person will be shown as tremors, tachycardia, palpitation because of sympathetic stimulation. But in these cases, that sympathetic system is blocked. So patients will not have those signs and symptoms of hypoglycemia and can cause some major issues. So that is why some physicians do not prefer to start beta blockers in diabetics. But again, and this is the reason. There is another group of drugs which act both on alpha and beta receptors. They are carvedilol, labetalol, and dalavalol. Again, when patient is on one of these, they should be continued in the morning of surgery. Another group of drugs, alpha-2 agonist in the brain. There are three types of receptors for these agents, A, B, and C. A and C receptors are mainly in the brain, so that leads to sedation, analgesia, and sympatholysis with minimal respiratory depression. And because of these reasons, dexmedetomidine, which is one of the agents in this category, or clonidine, is used for simple monitored anesthesia care, because they do not cause respiratory depression, but they are strong analgesics and cause some sedation. They are also used as an antihypertensive in the past, mainly clonidine, and that is because of alpha-2 B receptors, which are peripheral. They cause vascular smooth muscle relaxation, but again, the side effect is bradycardia and hypotension. If the patient is already on clonidine, patient should have the morning dose, because sudden withdrawal can cause rebound hypertension. Another vasodilators, which are mainly used as intravenous form and in acute hypertensive situation in the perioperative period, is hydralazine, which is a direct arterial vasodilator, can cause tachycardia through baroreceptor reflex. Nitric oxide donors, they act through the cyclic GMP pathway. There is nitroglycerin and nitroprusside. Nitroglycerin is more of a venodilator, whereas nitroprusside is arterial dilator. When we are using these agents, I would suggest and strongly recommend that you should have an arterial line to check the beat-to-beat blood pressure when you are using these agents as an infusion, because these are very potent vasodilators and can drastically drop the blood pressure. Nitroglycerin can be used in very tiny doses, like 5 to 10 micrograms as a bolus, to bring the pressure quickly down. Nitroprusside is becoming out of favor because we have other agents available. Still, it is used in situations of pheochromocytoma and the perioperative management of that. I put milrinone as a PDE3 inhibitor here because it is an inodilator. That means it has positive inotropic action plus peripheral vasodilator. It is used when there is RV dysfunction, when there is pulmonary hypertension, when the left ventricle is dysfunctional or low ejection fraction with hypertension. So you will kill two birds with single. So you improve the cardiac output, improve the RV function, decrease the pulmonary resistance by this, as well as controlling your blood pressure. Again, used only as a short-term intravenous single bolus low dose or as infusion. Never use as oral form. So let us now talk about management of hypertensive patient coming for surgery. So preoperative assessment. First, we need to know what is the cause of hypertension and for how long patient has been suffering from this. What kind of treatment patient is on, and is it adequately controlled or not? We also can take this opportunity at this time to counsel the patient for lifestyle choices, modifications, and they should carry on with the treatment. We know that the swings in the blood pressure in the perioperative period are much more in hypertensive patients. More so if the blood pressure is uncontrolled than controlled, and controlled hypertensives also show more swings in the blood pressure than the normotensive patients. So more fluctuation in the blood pressure means more cardiac morbidity. And if the blood pressure is more than 170 over 110, there are definitely increased incidence of cardiac complications. So in the perioperative assessment, again, we have to ask or review about end organ damage. Ask whether patient has history of TIA or stroke, any cognition problems in the heart, any heart attack or chest pain, any left ventricular hypertrophy, history of heart failure or arrhythmia. We have to look into the kidney function. Then we also have to inquire about the peripheral vascular disease or any aneurysm anywhere in the body. Then investigation wise, of course, we do ECG. We should do echo only if the blood pressure is uncontrolled and patient is not aware of blood pressure or is not compliant with the medications. However, if the blood pressure is very well controlled, patient is compliant, and when you check the blood pressure is normal, then it is your call to go for echo or not. In North America or in Canada, we do not send patients for routine echo if the blood pressure is well controlled. Of course, we check the renal function and electrolytes because of diuretic related electrolyte imbalance. In the perioperative period, we continue all antihypertensive medications except, as I mentioned, ACE inhibitors and ARBs. These drugs we stop 24 hours before, so do not take in the morning of surgery. Except these two, rest of the antihypertensive drugs should be taken in the morning of surgery. Then blood pressure should be adequately controlled in the operating room. We expect more fluctuations, so we should be ready with treating both hypertension as well as hypotension. We try to maintain the blood pressure within 20% of the baseline. And when I say baseline, we need to find out what was the baseline pressure, which is not the pressure you took just before induction of anesthesia, or you saw this when you saw the patient just taking him or her to the operating room. So this is the blood pressure where patient is normally working at home or when is totally under no stress and using their daily activities. So that is the baseline blood pressure. We try to maintain 20% during the operation. And we prevent hypotension again because of obvious problems with the kidney and the brain and the coronary circulation. These patients again tolerate hypovolemia and vasodilation very poorly, and we should also focus on pain control because pain is one of the risk factors for intraoperative hypertension. When there is a sudden surge in the during surgery, that blood pressure suddenly goes up, then these are some common causes like pain, coughing, bucking, patient starts moving with the skin incision, there is light planes of anesthesia, or simple hypoxia or hypercapnia because of the tube related issues, or oxygen delivery problems, or rarely intracranial hypertension. Maybe if there is a intracranial hemorrhage, then you will have sudden increase in hypertension, blood pressure, and decrease in the heart rate, which is the Cushing reflex. Our surgeon has injected something with epinephrine, and that has got absorbed or got intravascular injection. Urinary retention is again another thing in the post-operative period to look for before we treat this blood pressure. Again, treat the cause, which I discussed in the previous slide, and after that, which we have immediately available to us in the operating room, is the inhalation agent. Simply go to the dial and increase the percentage of whatever agent you are using, or simply inject some propofol, which is just close to you. After that, you can of course use labetalol, esmolol in frequent aliquots in small doses, and these are the short-acting drugs, so preferable to use these. But if your patient is requiring more and more of these, then you can resort to IV metoprolol, which is a longer-acting drug. So you have to make sure that you are injecting this drug only when you think that patient would be hypertensive for a long time. Otherwise, this can cause bradycardia and hypotension, which will be difficult to treat in the intraoperative period. Uh, Clobazam is a very short-acting calcium channel blocker, again very popular for sudden surges in the blood pressure intraoperatively. We can also use hydralazine and small doses of nitroglycerin as a bolus. When we think of giving infusion, then again, as I mentioned, we should have an arterial line before we resort to use of nitroglycerin. So coming to our frequently asked questions, so what is the ideal preoperative blood pressure? And I would say what is the new definition, which is 120 over 80. Okay, we can go up to 130 over 80. There are no published guidelines on this issue. So this is just a recommendation that blood pressure of the patient during surgery, before surgery should be as normal as possible, which is ideal. Again, at what level of hypertension we cancel an elective procedure? So again, there are no published guidelines, but the recent data and some studies, this was an editorial in 2017 mentioning that any elective procedure should be canceled at a blood pressure of 180 over 110 or more. I should also mention about the white coat syndrome here. So we have to really remove all the possibilities of anxiety, which is causing hypertension or aggravating hypertension before we cancel this operation. How much time does it take after adequate BP control to reverse the changes in the heart? Left ventricular hypertrophy can be changed. Left atrial enlargement is reversible. Diastolic dysfunction to some extent, not completely, but it takes many, many months. In one study, it showed that the significant improvement occurs only after 7.5 months. So definitely more than 6 months, maybe 1 or 2 years before you see the significant improvement in the LVH and in the left atrial dimensions. Diastolic dysfunction, nobody is sure whether it is completely reversible or not, but definitely it is improved. So case 1, so what factors we will consider for planning GA for this patient? Of course, what is the baseline blood pressure of this particular patient? That will guide us at how much blood pressure we should maintain intraoperatively. What medications patient is taking. So we have to ask in detail during history and examination of this patient. What is the RCRI of this patient? If RCRI is more, then after surgery, we should send some troponins for 3 times to rule out any perioperative myocardial ischemia, which is very common in this kind of situation. We also need to find out and review of systems of end organ damage, any history of stroke or TIA. Of course, she had heart attack and she does not have angina, but what is the renal status? So need to check the renal function and see the electrolytes as well. Again, as I mentioned, transthoracic echo, if the blood pressure is not controlled, then yes, but if it is properly controlled and patient is already compliant, then of course there is no indication for elective transthoracic echo. What are our hemodynamic goals? Blood pressure should be maintained within 20% of the baseline. So if your first blood pressure reading is 210 over 130 millimeters of mercury, of course I will give some sedation in the form of midazolam, maybe 1 or 2 milligrams, and wait for some time. Maybe in one patient, I clearly remember I gave some fentanyl and patient was snoring in the operating table and blood pressure was still very high. So if it still remains high despite giving adequate anxiolysis and sedation, and you think it is a real severe hypertension or hypertensive crisis, then again, any elective surgery should be cancelled. So we will postpone this operation once we rule out that it is not because of anxiety. Case 2, again, a very emergency situation. Time really matters in this situation case, either going for thrombolysis or a removal of the clot from the carotids or from the cerebral vessels. So how would you manage? I will immediately insert an arterial line. Sometimes by the time we reach there, the patient is already on the table and the radiologists have already started the procedure. And so there is not enough time to inquire much about the history and details. So the choices between GA versus sedation. In our center and in me, I would prefer sedation, a light sedation generally speaking, especially with the GCS of 12 and especially if the patient is cooperative. However, if it is a posterior circulation stroke, evidence suggests that And because the patients are not very cooperative, they are thrashing around, they're causing more problems with the procedure. So it is better to have GA in those situations. So posterior circulation stroke generally is done with GA, and anterior circulation stroke, it is sedation. But again, of course, it depends on your choice, your confidence and comfort level. How much time do you have? If patient is cooperative and is okay, then probably mild sedation should be enough. I would then again manage the blood pressure, bring it down to about 140 millimeters or less systolic pressure by using hydralazine IV or labetalol. And rarely we have to start GTN infusion because we already have an arterial line in place. And so what is our postoperative target for this patient? It should be definitely less than 140 millimeters systolic. So not in this patient, but if patient is coming for the coiling of aneurysm after subarachnoid hemorrhage or brain bleed. So there also we do coiling in the neuroradiology suite and with the similar procedure. And in that case, maybe sometimes the neuroradiologist want to keep open the artery and to prevent the vasospasm. They tend to like the blood pressure to be on the higher side of normal. So again, 140 is higher side of normal, I would say, or maybe more than normal. So probably blood pressure systolic should be around 140, not more than that. So that concludes my talk. So in conclusion, again, hypertension is very common. About 45 to 50% population may be suffering from hypertension or high blood pressure because of this change definition. I call it a slow poison because it has very long-term multi-organ problems and it is a major killer. And majority of the times by changing the lifestyle, we modify our lifestyle, we can manage this culprit. Adequate control is must, and it takes at least 6 months to 1 year before we see some changes in the ventricular hypertrophy or atrial enlargement after adequate control. So we should continue antihypertensive medications except ACE inhibitors or ARBs on the morning of surgery. We expect that be prepared with swings in the blood pressure if we are doing GA in these patients. Perioperative management of blood pressure should be within 20% of the baseline. We should have autoregulation in mind, especially if patient is uncontrolled hypertensive and comes to you for an emergency operation. In that case, we should not certainly drop the blood pressure significantly. Again, perioperative targets depend upon adequacy of the preoperative control, comorbidities patient is having, and the type of procedure is patient undergoing. And lastly, very important to prevent hypotension because that can cause renal failure or a stroke or postoperative delirium or confusion. And thank you very much.